Sir, lots of talk is going on the timing of the primary PCI. So, in relation to that, I would like to ask you, what are the parameters that you would like to consider to optimize the primary PCI outcomes?
The most important thing is the time at which the patient arrives and the time gap between the symptom onset and the passage of the wire. So that is basically, some of these things are not under our control, or whoever is doing the primary angioplasty, because you have to get the patient on time. And once the patient reaches your hospital, you can have your systems optimized so that the patient, once the patient reaches the emergency room, he should reach the cath lab at by a fastest route. That one we can optimize because that is under your control. Then activation of the cath lab, and as early as possible you have to pass the wire and get the flow. That is the most important thing. And along with that, the second thing is, here the culprit is the thrombus. So you need an optimal antithrombotic strategy at the same time without producing an inadvertent bleeding. So now we have very potent antiplatelet agents. They should be administered at the earliest at the correct and the proper dosages, so that we can do the procedure under a proper antithrombotic umbrella.
Right, sir. So, sir, it is said that the time save is a muscle save. Absolutely. So, we should make justice to the golden period once the patient develops the chest pain. So, what will be your key recommendations to the patients, to the physicians who are managing the patients of MI?
Most important thing is the patient should be aware of the fact that he is developing a myocardial infarction or a heart attack. Unless and until he knows that it is the symptom or warning symptom of a heart attack, the chest pain is the warning symptom of a heart attack, he will waste time by thinking that it is gas or something else. So one is awareness. People should know about which are the symptoms of heart attack, and once they identify the symptoms, they should get a medical help at the earliest, so that the first medical contact, symptom onset to the first medical contact time gap should be shortened as much as possible. Then the current reperfusion modality of choice is of course primary PTCA. If you can get a primary PTCA done within 120 minutes, then that should be the treatment of choice. So then it depends upon whether he is presenting to a hospital with a primary PCI capability, or he is presenting to a hospital without primary PCI facility. If it is with a primary PCI facility, at the earliest you should get it done within an hour. So you have to optimize the systems in the hospital. If it is presentation is to a hospital without the facilities for a primary PTCA, and if you can transfer and get the primary PTCA done within 120 minutes, of course you transfer and get it done. Otherwise you have to lyse the patient on site and then transfer to a facility with a PCI capability, and then get the completeness of the revascularization done within next 24 hours. Right, this gives the best outcome.
Right, sir. So, sir, early reperfusion is the key for the management of patients with the STEMI. So, to achieve that early reperfusion, whether we are achieving with the primary PCI or whether we are achieving with the thrombolytics, it might be immaterial. The objective is to achieve the reperfusion early. So, in relation to this, according to you, what is the place of thrombolytic agents in the achieving early reperfusion?
Look, thrombolytic therapy when compared to primary PTC, its advantage is right now we are using the bolus agents which can be immediately administered, and the time gap as per the current guideline is you have to administer it within 10 minutes. It's only a 2 minutes procedure, so you can give it in the ambulance. So you can give a early reperfusion therapy by utilizing a thrombolytic therapy. But you cannot give a complete reperfusion with a thrombolytic therapy because there is a failure rate of 20%, a reocclusion rate. So completeness can be achieved only by a mechanical reperfusion therapy. So in those places where they don't have an access, the population doesn't have an access to the reperfusion therapy by mechanical reperfusion or primary PTCA, then thrombolytic therapy is the answer. But it is not a complete therapy, that is the issue. After the thrombolytic therapy, you should get the complete revascularization within 24 hours. That is the current recommendation.
Right, sir. So, sir, do you think that there is some scope for the pharmacoinvasive approach, particularly in countries like India?
Absolutely, especially in countries like India. Especially I'm from a place, the southern part of India, Kerala. But our population access, with the study which was published in the Indian Heart Journal, population access to reperfusion strategies. Our 92% of our population in our state have an access to reperfusion strategy, either lytic therapy or primary PCI. And primary PCI, more than 70% have a timely access to reperfusion therapy.
Right, sir.
And we have a registry on primary angioplasty, close to 6,000 patients, 1 year follow. It is unpublished data, but the mortality is close to 5%.
Okay. So, sir, what will be your final key message to the practitioners and the cardiologists for managing the patients of STEMI?
Cut short the time from the symptom onset to the arrival in the cath lab and an optimal antithrombotic therapy.